It's a real pleasure to be here with you in Paris for this 1-hour PCR webinar entitled DCB PCI in Clinical Practice, Negotiating the Learning Curve. Now, in generating this title, I have to say it very much reflects the excitement and my engagement in DCB PCI over the last 1 to 2 years. But I'm here today with experts in the field. It's my great pleasure to be joined by Thomas Rissanen from Finland and friend and colleague Gabor Toth from Austria to hopefully join with you in the objectives as we've outlined. These are our disclosures. But the objectives as we hope to cover in this next 1 hour are to consider the practical steps in vessel preparation. I have to say in my practice, this has transformed the way in which we get decent outcome from DCB PCI over the course of the last 1 to 2 years. To consider how we deal with vessel dissection, this is incredibly challenging, but I think really important in our development of this practice. And then importantly, to consider what represents an acceptable DCB result. So it's our intention to use cases as a platform really for developing these objectives together and hopefully then to learn over this 1 hour period about how to best manage DCB PCI. There is huge excitement. So we saw at this year's PCR really lots and lots of debate and presentation around the use of DCB, and we can see just scrolling through PubMed, this exponential rise in reporting and publications relating to DCB. At the same time, I think we have to be cautious in terms of understanding the existing indications and where we're moving in the future, but really dependent upon ongoing clinical trials. Now, Thomas Rissanen was part of this most recent consensus, the third consensus document in the role of DCB in the treatment of coronary artery disease, and we're going to use this as a template really to outline our use of DCB in intervention. So as it exists, the current indications for DCB really are in-stent restenosis, de novo small vessel disease, and then high bleeding risk, which is one of the cases we're going to share with you this evening. And then there are extended indications, the role of DCB in bifurcation, and Gabor is going to share with us a case highlighting the role and utility of DCB in this setting. And then clearly the excitement and much of the discussion is now around de novo large vessel disease, but I think it's important to reflect that a large ongoing study is in the process of recruitment, and really we need to wait for the results of this to gain a true understanding of where DCB treatment sits with de novo disease. So Solution De Novo is led by MedAlliance. Now this week it's been confirmed acquired by Cordis, our sponsor for today's webinar. And this is a direct head-to-head comparison of DCB against drug-eluting stents in true de novo disease, and all three of us are very excited to be participating in this trial. Now, Thomas has outlined beautifully in the consensus document how we should go about DCB treatment, and this is something that with the cases we'll share, we will further emphasize. But really the key here is vessel preparation and the need to consider really very kind of sequential predilatation of the lesion, maybe starting semi-compliant into non-compliant, but importantly a 1-to-1 ratio of balloon to vessel diameter. And then the use of adjunctive technologies becomes really important. So the use of a cutting or scoring balloon and even adjuncts such as rotablation, intravascular lithotripsy may be necessary. Now, in terms of what equates an acceptable angiographic result, this very much reflects the guidance in the Solution De Novo study, which is to avoid leaving flow-limiting dissection, to achieve an expansion of the vessel without residual stenosis of more than 30%. And if FFR has been used, we're not necessarily going to have time today to touch upon physiology, but if it's used, then certainly an FFR above 0.8 or maybe higher, but we're again learning at the moment. And in terms of this issue around suboptimal result, then really, this is where we have flow limiting dissection or recoil of the vessel, and hopefully we can share through our cases some experience in terms of the decision making and the dilemmas we may face in clinical practice. And I think dissection is the one that we probably most fear, and is for me actually one that has been an evolution in the adoption of this technology in terms of understanding what we mean by non-threatening or threatening vessel dissection. And so the historical classification A to F, in my opinion, I don't feel is entirely useful. And instead, really, it's important to focus that within this type classification, really the focus is on the persistence of contrast, the staining of contrast within the vessel wall, and potentially reduction in flow that might equate to vessel-threatening dissection. And so, again, we can share that experience through the cases that we're going to share with you this afternoon. Now, this is meant to be an interactive experience, and so I'm tasked with manning the iPad, and I would ask that if you have questions or you have comment throughout this time, that you join us and engage with us by sharing those comments, and we'll do our very best throughout the presentation to incorporate those into our discussion. So with that, I'd like to hand over to my colleague Gabor Toth to take us through the first case. Gabor.
Thank you, Tom. So the first case what we would like to share with you is an old patient with severe aortic stenosis, no relevant angina, a good LV function, a significant aortic stenosis, and as performed in the context of pre-TAVI workup, we have performed a cornea angiography, which showed the following. On the right corneal artery, there was nothing really remarkable. And on the left side, we have seen the following. I just let you all have a look first, just like in the everyday practice. We see all the three different projections. And now in actually what you can see here, that the circumflex has an ostial disease, while in the LAD diagonal bifurcation, there is a complex calcified lesion involving both daughter branches. So let's just stop here and let's make a strategy for this coronary artery disease in the context of topic of DCB.
Yeah, so Gabor,
Thomas.
You say in the context of DCB, but this is challenging disease regardless of strategy. So you're demonstrating very nicely this really quite critical stenosis within the ostium of the circumflex, and then smaller caliber but complex Medina 011 disease, LAD diagonal. So yeah, Thomas, tell us, how would you approach this in your daily practice?
Thanks, Tom. Very important question. First, I would like to consider the LAD diagonal. There's a little bit of calcification on the both branches. I would probably use either NC balloons or cutting balloons, and then using 1-to-1 ratio balloon to the vessel could have a good prelocation, and after that decide whether to use DCB only for both vessels or DCB only for the side branch and then stenting the main branch, or do we need a two-stent strategy? And similarly with the circ ostium, I would do good prelocation, probably with cutting balloon, and then judge if the case is suitable for DCB only, which makes it quite simple as compared to stenting from the left main.
Okay, but your approach would be one of pre-dilatation and leaving open decision regarding DCB or not, dependent on how the vessel behaves. Correct?
That's true, because you have to make the decision after predilatation according to the international consensus criteria. So you cannot do it beforehand, having not touched the vessel.
Now you mentioned cutting balloon. So my interpretation of the angiogram would be that that would be incredibly difficult to deliver up front. So presumably you'd go sequentially non-compliant balloon. Would you then take a cutting balloon regardless of how that non-compliant balloon behaves, or is there anything that you react to in terms of the angiographic appearance of the balloon inflation?
Yeah, you are absolutely right that cutting balloon is quite difficult to have, bend to tight corners. So I would probably use for the circ a smaller semi-compliant balloon, and then use 1-to-1 balloon to vessel ratio cutting balloon. Maybe 2 wires is needed for the passage of the cutting.
And then just picking you up on the strategy in terms of making that decision towards DCB, you mentioned about treating the side branch first with a DCB. So you're committed to predilating the diagonal, and then you're going to apply drug before deciding on stenting or drug-coated balloon to the main vessel, LAD. Is that correct?
Yeah, after stenting the main branch, you have to put the cutting DCB through the stent rods, and you may lose some of the drug. So I prefer using DCB up front of stenting of the main branch. So you have to make that decision before. But if it needed, you can do it after stenting, but you have to open the struts before putting DCB to the side vessel.
So that's an important point. If we could just have the slides back, we'll just expand on that maybe while we get Gabor's opinion too. So this idea about the approach to the bifurcation, Thomas, with his experience, is suggesting, if we just move forwards with the slides, is suggesting that you go about actually a fully DCB approach to the main vessel and to the side branch. But obviously in a hybrid approach, if we could just move forwards with the slides, please, then we can see actually that you may treat the main vessel by stenting, proximal optimization, and then as Thomas said, sorry, as I just go back through this because it just leapt ahead, the important thing here would be to dilate the stent struts into the side branch before considering deployment of the DCB, for fear of the fact that you disrupt the drug, the excipient, the polymer and nanoparticle in the setting of solution in passing through the struts. So the stent up front followed by DCB requires this expansion into the side branch. Or as Thomas was suggesting, you actually prepare and treat the side branch first with DCB, and then you still have open the option of DCB to the main vessel, or in this stent DCB hybrid approach of then stenting the main vessel and optimizing with POT. So Gabor, do you want to just talk about how you went about this and then maybe show us the case?
Sure. So I think the most important thing here that, as Thomas also said, that you start with lesion preparation and keeping open for different options. You have to achieve proper lesion preparation, actually, regardless whether you will put stent or put DCB at the end. But you have to achieve a good result after lesion preparation to decide how you want to move on afterwards with the stenting or DCB.
Yeah. So Gabor, just before you do go on, we've got a comment from Rafiullah Jan from Pakistan, who says he's a big fan of DCB and de novo lesions, but the concern is around this management of dissection, which is one of our objectives. But how do you deal with long segment treatment, and how do you recommend vessel preparation in that context? Don't know whether that's best with you, Gabor, or with Thomas, in terms of anticipating
let's
change.
focus on lesion preparation here, and regarding long segments, we will discuss definitely during the second case.
Okay.
So lesion preparation, again, as said, you have to achieve with lesion preparation a result which already sufficient in terms of no relevant recoil, no flow limiting dissection. And when you see this, you can decide whether you use a DCB, which very important, DCB will not dilate further the lesion. DCB will just deliver the drug. So if you are not happy with the angiographic result after lesion preparation, then either you prepare further or this is a case for stent. If you want to consider DCB, then with lesion preparation, you have to achieve a result, which is already a quote-unquote perfect result because DCB will not further dilate the lesion.
Yeah. Okay, that's a really important point, isn't it? That the application of the drug with the balloon is not ballooning, it's just simply delivery of the therapy.
Exactly.
So you have to be sure that you've achieved the result you want prior to the delivery of the drug. Okay.
Exactly.
So take us through what you've done then in this highly complex double bifurcation.
So what we did, if you can see now the slides, I would like to show first what we did in the LED diagonal bifurcation. So it was clearly a highly calcified lesion in both directions. So to achieve good lesion preparation, we performed 125 and 1.5 rotablation first towards the diagonal, and then 1.5 rotablation towards the LED. After rotablation, it was still clear that we need further dilation in the LED continuity. So we used here an IVL. We needed to use an IVL, and after the IVL, I have to tell you that we did not consider for this case a DCB only approach, but we wanted to put as regular in a provisional strategy a stent in the LED. We put the 3 millimeter stent, performed the proximal optimization, and after proximal optimization, we performed a proper kissing with a 3.5 and a 2.5 stent. And then it looked actually angiographically a nice result, but considering the extent of disease towards the diagonal, which is a big diagonal, considering that it was definitely a big plaque burden, which we massively modified with rotablation, then with the ballooning and so on, although it was a acceptable provisional result, we wanted to have achieve a long-term better result, considering a long-term better result with delivering some drug to the side branch ostium, the proximal side branch, which is the locotypical for target lesion failure for bifurcation.
Gabor, I just wonder if we can pause at this moment, just because we obviously outlined the potential treatment up front with DCB and then stenting, or this approach as you've outlined with DCB and non-compliant balloon as a kiss. And I presume your reason for kissing is that, particularly with the presence of the stent, you want to regain the geometry of the bifurcation. So is there a role for pot side pot, or you just put the DCB into the side branch and then go back and optimize the main vessel? Is there a detriment to kissing with a DCB?
With pot side pot, I have other concerns, and I'm not much favor of that approach. I think if you want to open a side branch, then the kissing is the right way to do so. But what you mentioned, whether first DCB and then kissing or the other way around, I think if you perform the proper kissing, then after that, crossing with the DCB towards the side branch should not make any resistance. I don't believe then you lose much drug from the surface of the balloon if a proper kissing was already performed, because then struts are already widely open. You have a straight way to go. So I'm not much afraid of this, but I want to finish with a kissing step as to maintain the central line of the carina and so on.
Okay, great. I mean, within the solution study, interestingly, this kissing inflation is one that we're told to avoid, although there's no data to support doing it one way or another. But potential interaction between the drug on the drug-coated balloon versus the other balloon is said to be the reason why you would treat into the side branch and then manage the main vessel again. But this is, I think, an evidence-free area, isn't it? We've got.
I can tell you what we might consider, and time to time we perform it that way, that you come with two balloons for the kissing already in position, you inflate first for a whole minute the DCB, but then just to close this step, you inflate at the very end the main branch balloon and deflate simultaneously.
Yeah, just simply for that geometrical return to optimal. We're getting the most incredible amount of questions, not all of which I think we can answer within the context of the case, but we will endeavour to in the discussion. But there is one that's, I think, relevant to this point. I mean, Thomas mentioned about using cutting balloon, going from non-compliant to cutting. You've gone upfront rotablation, diagonal and LAD. There's a question here just about the role of DCB in heavily calcified vessels. So Usha Rao has asked, is DCB effective in calcific disease? Are there trade-offs? What are your thoughts in terms of different lesion characteristics and how DCB might behave?
So it's a very good question. What is my opinion? Because I think this is definitely a field where the strong data are still lacking. I fully understand the concerns about the efficacy of DCB in the calcified lesions, and I think we don't have the data yet to confirm that it works. But what is also important to consider, and especially in smaller branches like here, the diagonal with the 2-5 vessel, where we did rotablate, we did a predilation, everything, but still, these are the cases where to achieve a good stent result with nice circularity, nice apposition, nice expansion all over, it's often a wishful thinking.
Yeah.
And sometimes I like to interpret it rather in the way that suboptimal result with a stent, which is sometimes the best what you can achieve, it's also not that safe for long term for the patient. And compared to that, nice flow, no dissection, treating with DCB, like in this case in the side branch, I strongly believe, or my opinion is that it might be a valid option for such calcified lesions.
I mean, you could go one step further and say that with very calcific disease where the stent is unlikely to fully oppose the vessel wall, just applying drug and not leaving behind malopose struts may in fact be more attractive rather than just an acceptable equivalent. There are comments here about the role of imaging and stuff, so Sejan Narayanan is asking, but maybe we'll extend that into the discussion in a moment. So do you want to take us through then how you've dealt with the left main circumflex bifurcation as well, Gabor?
Let's focus on the left main slide. Yeah, I'll just show you very quickly the final result because we missed it. If you see it now.
Yeah, it's up.
Okay, so and what we did for the left main, it's clearly an ostial circumflex lesion, highly calcified. Here we started with the scoring balloon towards the circumflex, and then 4-5 stent was placed from the left main to the circumflex, performed a 5-0 pot, and followed by 3-5, 4-5 kissing, 4-5 towards the circumflex, 3-5 towards the LAD. The result was good, no major issues towards the LAD, but still we performed again the same way, 3-5 towards the LAD and 4-5 towards the circumflex, kissing DCB towards the LAD. Here, the concept is a bit different compared to the previous case, compared to the previous bifurcation, because here, for me, it was not the plaque burden which justified to use the DCB towards the LAD, but rather all the potential vessel injuries caused by the kissing balloon dilation, and there just with the idea to avoid any, in this case, so-called side branch ostial target vessel failure, consideration was delivering drug there might provide a better maintained long-term result.
you want to take us to your summary slide, Gabor?
Yeah. So the patient a few days later underwent successful TAVI implantation. So for me, what this case has as memorable, that bifurcations in my practice are good targets for DCB, especially for the side branch, and DCB can be a valid option even for highly calcified lesions, with the consideration what Thomas just explained. And proper lesion preparation is, it's the key for any kind of PCI, but for DCB, the very important message that DCB will not dilate anymore. DCB will not improve the angiographic result. DCB will just deliver the drug. So what you achieve before with lesion preparation, this is the ultimate goal before you decide to deliver a drug with DCB.
Fantastic. Gabor, a lovely case. So we are getting lots of interaction, which is fantastic. So a couple of questions which I think are based around a similar concern, which is about this loss of drug from the balloon. Thomas, you mentioned about not wanting to lose it in passing through a jailed side branch, the struts. There's another consideration here from Yanis Rukas about tortuosity and potentially loss of drug through that tortuosity. And then there's another kind of procedural consideration around this use of kissing balloons, Gabor, and the potential interaction between the balloons potentially resulting in loss of drug. So maybe I can start, but it would be useful to get maybe Thomas and Gabor's opinion too. Obviously, the concern with the excipient type drug-coated balloon, where the drug is held underneath the crystalline contrast, then clearly there is a time issue in terms of the drug starting to elute from the device. So we actually we start a clock as soon as the device is placed in through the manifold, and if it exceeds a minute, we actually have to discard the balloon and use a new balloon. So it implies that if you haven't adequately prepared the vessel and you have concerns around delivery of the device, you're really not ready to deploy the drug. Now, actually, solution behaves slightly differently in that this is drug held within a nanoparticle on the surface of the balloon. And so this time to delivery is less of a concern. But again, the same issue around tortuous or through struts of stent, loss of the polymer, loss of the drug may be something that's relevant. Thomas, I don't know whether you want to add anything to that in terms of concerns procedurally.
Yeah, you are right that long lesions, tortuosity, calcifications are quite difficult for DCBs because they are quite bulky devices. But luckily, there are differences between DCBs in terms of crossability, for example. I'm not sure if there are data on how much drug is lost. Maybe somebody has done some bench testing, but I haven't seen it. In clinical practice, we haven't seen an issue about it. So that's my answer.
And then Gabor, from another procedural consideration again, Yanis Rukas asks about the left main inflation. So this need to deliver drug over a minute. How do you go about safely deploying or delivering the drug for that period of time?
Yeah, it's a very good point because, again, it was indicated on the slide that kissing with DCB, and this is what you also mentioned. But of course, it's not, especially aortic stenosis, codominant left system. You will not inflate kissing balloon for 1 minute to deliver the drug. So in this case, it was kissed in a way I mentioned that both balloons were delivered in place. The left main LED DCB was inflated for 1 minute. In this huge left main, it was clearly not occlusive for the whole left main, but just towards the LED. And then the whole minute was closed by inflation of the left main circumflex balloon and simultaneous deflation.
Yeah, okay, brilliant.
Importantly, before that, a proper kissing was already performed. So again, you don't expect much stent deformation coming from the drug delivery balloon. So you don't need, with the final inflation of the left main circumflex balloon, it was really just to centralize the carina and have a good final result. Yeah.
So that very much answers Mohammed Wakas Mazhar's question as well about whether you go back and undertake further non-compliant post-dilatation after delivery of the drug. I think the message we're wanting to give is that the drug application is very much the finishing element to the procedure. So you're achieving your final result by angioplasty, and only once you're happy with the result do you then deliver the drug before completing the case. And hopefully we can reinforce that again.
It's also a good marker, the nominal pressure of these DCB balloons. The pressure where you deliver the drug is normally around 6 or 8 bars. This is not the pressure what you use for a proper balloon dilation, proper kissing, whatever. This balloon just comes there, touches the wall, delivers the drug, and fine.
Okay. And it'd be really, before Thomas, you share your case, just with your experience, in terms of, there are lots of questions around the calcific nature of this incredible case Gabor shared with us. Do you have any concerns around the drug delivery into calcified vessel versus a non-calcified lesion? Someone's asking, do you inflate the balloon for longer? Should we be doing things any differently to a standard lesion?
Tom, very important question. Actually, we have studied it in a study or trial we published 5 years ago. It was after rotablation we applied DCP only strategy. There was 70 patients. They were quite old ones, severe disease, also proximal LAD, even left main stair. And actually the clinical results and restenosis rate was low. And after that, I think many Japanese groups especially have published similar studies. I haven't seen IVL studies yet, but I would say that there's probably no issue combining IVL and DCB. I think that especially paclitaxel, because of lipophilic nature, could travel also quite well in calcified vessels. But for example, animal models are very difficult to be created on calcified vessels, so we don't have any data from that.
Okay. This is all fantastic discussion, and thanks for everyone interacting so much. I'm fearful that with Thomas's case now, we're probably not going to finish before 7 o'clock. So, Thomas, it would be lovely for you to now share with us your case on a high bleeding risk patient, and I'm sure this is going to generate even more discussion.
Thank you, Tom. So my case is 78 years old female, conventional risk factors, and she was diagnosed with coronary artery disease 10 years earlier, and at that time medical treatment was carried on. She is obese and physically inactive. And very importantly, she was diagnosed with breast cancer and a very large tumor with metastasis in lymph nodes, and was waiting for urgent surgery and adjuvant chemo and radiation therapy. She had CCS3 angina at the pre-op visit and was referred for cardiological exams. Echo showed normal ejection fraction, and then we performed coronary angiogram. Here you can see the right system or right coronary artery. There is a very tight lesion just before the crux, and then 2 eccentric lesions in the middle RCA. And I would say that also reduced flow in the distality. Here you can see the left system. There is a stenosis of the distal left main, and also in the mid-circ, just after the ostially diseased marginal vessel, there is a hemodynamically significant eccentric lesion. And then in the LAD, there is also a significant lesion as studied with FFR. And here is another view on the proximal LAD. So, Tom,
Yeah. Okay. Well, I've been so involved in preparing for this webinar that I have to say I probably haven't stood back and considered the complexity of both your and Gabor's case. So Gabor, how are you going to approach this complex 3-vessel coronary disease in a lady awaiting urgent surgery for breast cancer?
Yeah. So it's clearly a complex 3-vessel disease, and you already mentioned that it's due to the comorbidities, this patient should be candidate for percutaneous revascularization. We have data for different stents in HBR patients. Probably our way would be to use one of them and trying to reduce the amount of stents as much as possible, and limit only for the most critical segments of the lesion to let her being operated as quickly as possible. And
so let me pin you down then, Gabor. You say limited number of stents. So where would you be stenting? Left main, short left main LAD, distal right?
Distal right, and LAD. Probably this would be our target.
Okay. And in terms of your antiplatelet therapy then, so dual antiplatelet therapy until surgery with interruption, presumably?
Dual antiplatelet therapy until surgery, or actually dual antiplatelet therapy until discharge, and after that kicking for single antiplatelet. Okay.
So actually you're joined by Martin Hudek in Graz, who is asking about the issues around DAPT. So Thomas, do you want to give us your take on this then in terms of antiplatelet treatment and how you decided to embark on this highly challenging disease?
Yeah, it's very, very important question. I think we may come to it also in the end of the discussion, but I consider the bleeding risk of the patient together with anatomical considerations and of the complexity of the disease. Of course, in this case, one could argue that you don't have to touch the left main at all, as Gabor said, only treat RCA and maybe LAD, and she would go for surgery. You don't have to revascularize everything, but because you increase the risk of putting many stents when you start treating all the vessels.
Yeah.
So, but here we aimed obviously for DCB only strategy, what we will see later on.
Okay, so maybe show us what you've done.
Okay, so we started with the right coronary artery. First of all, a decision for PCI was done, and no CABG because of the obesity and also the cancer. We used a 7 French radial approach, and to facilitate the delivery of bigger balloons, we used small semi-compliant balloon. This is the angio after the small balloon. You can appreciate that the flow is now a little bit better, and you can better visualize the eccentric lesions in the mid part of RCA. Then if we are going to aim for the DCB, or at this point we don't know whether we have to stent the vessel or can we approach towards DCB only strategy, but anyhow we have to use 1-to-1 ratio balloons, and we probably almost always use non-compliant balloons, as long balloons as possible, high atmospheres, and also long dilatation time to seal also the dissections and have a little recoil. And here you can see the result after predilatation with non-compliant balloon. And we have now 2 considerations. We have to look at the flow of the vessel, and then if there is recoil or not. It's best to have 2 different angles which are perpendicular to each other. I don't have the other angle here, but it's very, very good, at least in the beginning, when you start your own DCB only operations, that you use two angles to be able to visualize the lesions after prep. And here we have two spots here with recoil. So
yeah. So if we leave this up, Thomas, because it's a really important image, I think, and certainly in my learning curve, this is something that I may have bailed out very quickly to stent. But we talked about the challenges around the dissection classification. So we see clear evidence of vessel injury, particularly in that kind of segment 2, the second blue arrow on the still frame. But importantly, as I suggested in this threatening, non-threatening, more simplified classification, in my mind now, then you see clearance of contrast, don't you? So there's no hold-up of contrast around that dissection. And importantly, the distal vessel, as you said, and we've got enhancement of flow, having had what was TIMI-1 flow at the beginning of the procedure. So Gabor, how would you be dealing with this now? Is this acceptable? Do we now just go on and put the DCB in, or do you bail out to stent, or is there more work to be done?
Well, I think considering the consensus document by Thomas and colleagues, it's still not good enough for DCB as it is, because you still have relevant recoils. So I think if you want to go for DCB alone, then you should further dilate these segments to see whether you can achieve a result with no recoil. Or if you think that there is always this recoil happening, then it might indicate normally to put a stent.
Yeah.
But then you have to consider what was the reason why you wanted to go for a DCB alone strategy, and what spoke for not to put a stent at all. And I think this is really, in this case, it's a very patient-tailored, individualized decision.
Yes. So Thomas, there are a couple of questions that kind of extend from this. So in terms of next steps, someone's asking, probably back to Gabor's case, about the role of OPN. So would you just take a higher pressure balloon? I'm interested by your use of the 3.0 non-compliant at high pressure. Simon Eccleshall in the UK, who's very much pioneered from a UK perspective DCB use, has kind of taught us to go relatively gentle, so not to use high pressure inflations, but maybe to graduate from non-compliant to scoring to cutting balloon. So that would be one challenge. And then Sejan asks us whether there's any role for intravascular imaging to guide our subsequent decision making. Could you comment on both of those? So the sequence of incrementing pressure, device, complexity, and then the role of imaging. And then perhaps you're going to show us what you've done.
Yeah, very important questions. So what Simon does is absolutely appropriate, especially in the beginning when you don't have much experience on DCB, to go sequentially from small balloons to larger ones and see what happens to the vessel. You know, I have quite a lot of experience, so I tend to go directly from the very small balloon to facilitate the passage of the one-to-one balloon. And then, of course, there was some calcium in the vessel, and also because of the eccentricity of the two spots, I used higher pressures. And then, what was the other question?
About imaging. So does imaging potentially play a role? Because that hasn't really played any major focus in the consensus documents or anything, whether that's evolving in experience.
Yeah, the consensus document is about the flow and also the angiographical appearance of the vessel. Question about imaging is very interesting, but we don't have data to support the use of imaging in the context of DCB only. It's very important to use it beforehand in the left main and LAD long lesions, also in RCA. But after DCB, we don't know how the vessel should lie inside. We only can look at the flow at the moment and angiographical recall.
So the angiographic assessment. Okay, so you're going to show us.
I turn this question to you, Tom, quickly, because just to use your imaging experience here, because I think it's a very important point what Thomas also mentioned now, that because with imaging to assess the result, so I believe that everything what we learned about how to use imaging to evaluate the result after a stent, this is completely invalid here, because of course you see dissection, of course you see some variation in the vessel lumen and so on and so on. So how do you use in your practice imaging to assess result after DCB, if you use it at all?
Yeah, so we're actually using it. You won't be surprised to hear that I'm using imaging in most of the DCB treatment, maybe in an overly thoughtful approach, but I do wonder whether there is more for us to learn and anticipate how lesions behave by understanding the lesion type. So we've talked about calcium, but then in a high burden lipidic plaque where we may see more dissection, it may mean that we tailor our preparation differently. So we've had this discussion with everyone online about OPNs, rotablation, IVL. Clearly, by using the imaging, we're guiding our lesion preparation. The anxiety, I think, as Thomas suggested, around the use of imaging in the setting of wanting to complete with a DCB is you see so much injury that you convert to a stenting approach, you bail out. And so the risk is you're going to just bail out more frequently. And so I have to say that our approach to using the imaging is very much in the pre-assessment and much less so in the post. So I will return to rely upon my interpretation of the angiogram rather than the imaging once we've created dissection and injury. And I think what's fascinating is you see the extent of injury by the imaging and see what it's safe to leave behind, and it's quite extraordinary. So this is such an exciting position that we're in terms of further learning, as I think was evidenced by the discussions and the cases that were shared at PCR and the ongoing discussion we're having this evening. So Thomas, maybe just for the purpose of time, we better get on and look at what you've done, and particularly as you're then going to share with us subsequent outcome data from this angiogram.
Okay, thank you. So here we actually left for discussion. So we had NC dilatations and 2 spots with recoil. So as both Gabor and Tom mentioned, it's not fulfilling the international consensus group guidelines. So we chose to use 3.5 by 6 cutting balloon here, just for the 2 problematic areas. And you can see that there are two wires to help the cutting balloon go down the vessel. So this is the preparation after both NC and cutting balloons. We have more space in this vessel, and also in the places that we had recoil, we have non-flow limiting dissections. So would you like to discuss this finding here, or?
Yeah, so I mean, there's a trade-off now, isn't there? As Gabor said, that you've made a decision up front here that this is a high bleeding risk patient who you want to do everything to avoid lots of stent. So I guess the question is, do you place a stent in the area where you've got recoil? Or as Usha online's asking, can we assume that with the delivery of the drug that in time passing we'll see positive remodeling of those segments? So can we anticipate that we'll have a better result in 3 months than we have acutely? So it's a trade-off, and I think this becomes more challenging and nuanced in terms of patient-tailored delivery. But maybe show us what you've done here, Thomas, in the context of this patient.
Yeah, we'll discuss about positive remodeling, but at this point, I would say that this section, as it's non-flow limiting, is actually positive. You probably see in those areas the highest rate of positive remodeling where you have controlled dissections, what you create quite often with cutting. So we continued the thinking here, and this is a borderline case for a drug-coated balloon because of the recoil, especially in the more distal area. But given the urgent surgery needed, we decided to go further using DCB only PCI in this patient. We used 3 long paclitaxel coated balloons, which are very importantly overlapping each other, and preferably at least 30-second dilatations up to 60 seconds for better sealing of the dissections and also better transfer of the drug to the vessels, to the vessel. And this is the acute final result. Again, we have to consider the flow and recoil. The flow is good. The patient was painless. And here also it's beneficial to have at least 2 angles, and which is very important, have the last angio done without the wire, which can actually hide some of the areas with dissections. It's best to evaluate the situation and dissections without the wire. And we actually stopped here because it looked fine to our eye. Then, in the sake of time, we already in this point had treated all the places or the lesions with DCB only strategy in the left system. You can appreciate the mid circ. It was bread-laminated with the cutting balloon, and we achieved a stent-like result. And there is quite big marginal vessel in the area. So quite often in this kind of cases, we use DCB only to prevent the compromise of the side branch ostium. And also for the left main and for the LAD, preludation result was very nice, and which is very important, we used a larger preludation balloon to the proximal LAD and left main, and then applied DCB to all places. The left main is a little bit problematic in some patients because, as you may imagine, there is quite often a drop in the blood pressure, ECG changes. But what we have learned is that at least in case of paclitaxel coated balloons, 50 to 20 seconds in left main should be enough according to animal experiments done past. And then in the end, again, we evaluate the patient, look at the ECG, and what is very important is that in using DCB, at least some of the lesions, you probably save some time, especially in terms of bifurcation treatment. And this is also very important here in the left system, that you obtain your last angio without any wire in place. In this patient, we decided to give only the loading dose of clopidogrel because surgeons were very eager to operate the patient within the next few weeks. So we didn't continue dual antiplatelet therapy. So this is only periprocedural DAPT used here, aspirin only from this point on. Then the patient had successful surgery of the breast carcinoma without any complications. It was done within the first 4 weeks after PCI. And the patient continued on aspirin only. And we already have some preliminary data, which is registry-based data about single antiplatelet therapy after DCB only treatment. Both our group and then Bernardo Cordese's group in Italy have published those papers.
So Thomas, maybe just to extend this, so because there's been a question here from Tajamul about the worry around acute closure, which I guess is one of those issues that we have in the learning of DCB, that you create this dissection, you create injury. The greatest concern is abrupt closure. And now you're throwing into the mix single antiplatelet therapy. The worry will be exposing us to an even greater risk of closure. What is your experience in terms of that as a consequence of this type of aggressive treatment? Yeah,
it requires experience. I would say that one should start with quite simple lesions, doing DCB only, and then using dual antiplatelet therapy to be comfortable with the PCI itself. And then when experience grows, you can more adjust the dual antiplatelet therapy or single antiplatelet therapy according to the patient bleeding risk or emergent surgery or whatever. So this is highly, complex patient and requires quite a lot of experience to do all of this.
Okay.
But it's possible.
I'm really sorry to have to cut discussion, but I know that you're keen to have used this case because she comes back for a further angiogram, and so if perhaps you can share with us the clinical context and then those subsequent images, we'll have to finish after showing those results.
Yeah. So the patient was fine for 3 years, but again she was presented to us with NSTEMI at this time and referred for nuclear angiogram. And on the left side, you can see the RCA just immediately after DCB only PCI. And on the right side, you can see the same vessel 3 years later. And you could appreciate the positive remodeling, I think, especially in the distal lesion where we had type B dissection in the vessel. And also the other places, the whole vessel looks quite good. And then here you can see the left side. On the left, you have the situation just after DCB only PCI, and then on the right side you have control angio 3 years later, and here again long-term sustained result with circ, and also in the left main and proximal LAD. And I would say that there's, especially in the proximal LAD, there is positive remodeling, but a new culprit lesion in the proximal ostial circ. Here on the right side, you can see the LAD, how it has actually enlarged. And of course, at this point, we had to treat the circ. We did, again, cutting balloon dilatation 3.25 by 10 millimeter, and then evaluated with angio, and you can see that there is recoil over 30%, and this cannot be accepted. And given we already used a proper sized balloon, which was cutting balloon, it's very difficult to create any better predilatation result. So we ended up having a stent here, and which is important, the patient is not at the bleeding risk anymore and can tolerate long-term dual antiplatelet therapy. And on the right side, you can see the last image. And I think it's very important in this patient that actually she has only 9 millimeters of metal, after all of these revascularization treatments.
Yeah. I mean, considering the complexity of the disease that you started with, Thomas, 3 years before, 9 millimeters of stent is quite remarkable. But it also reinforces a very important point, which is that DCB treatment isn't always in isolation, and this idea that you prepare and predilate the vessels and make an assessment of appropriateness for completion with DCB is essential. So your bailout to a stent demonstrates this fact that you have options throughout the procedure. So this ability to dynamically shift from DCB to stent, but again, giving you that ability to restrict the amount of stenting is a really nice example. We're running out of time. We have had the most fantastic interaction with everyone online, and I would like to really thank everyone for their engagement, particularly to Gabor and to Thomas for their fantastic cases and expertise in terms of fielding the questions. And if I just go to the concluding slide for our summary, please. So, I hope that we have reinforced our objectives, which is that, effective lesion preparation is critical to the success of DCB. Dissection, as we've shown, is inevitable, and the management of that, I think, is challenging, but with time and experience, it becomes much easier to distinguish between these threatening and non-threatening dissection types. Thomas and Gabor have shown incredibly aggressive lesion preparation, but this one-to-one balloon sizing being essential. The A to F dissection classification isn't helpful, but we have to be sure we understand vessel threatening. And as Thomas has shown very nicely, where we're not comfortable, then we can bail out to a DES, and that is not failure. That is just ensuring a safe and long-term outcome to our patients. So thank you for your engagement. Thanks to PCR and to the support from Cordis. It's been a fantastic hour of learning for me, and I hope for you, you've enjoyed it. Thanks for your engagement. Thanks, Gabor and Thomas.
Thank you.